one.
Good morning and welcome to the older adults section. And we are talking today about the FTag revisions and what the implications are for recreational therapy practice. And this is a member benefit that we wanted to bring to you. It's very pertinent right now to the field, especially for those practicing in long-term care. So today, my name is Betsy Kemeny and Jody Douglas is here. She's from the older adult section. I am actually the secretary of the American Therapeutic Recreation Association, but I also have worked in long-term care for over 25 years. And both of us have spent a lot of time going through the 700 pages of FTags to condense them and bring you some information today. So just so that we're clear on where we're going, we wanted to make sure that all of you at least end up with some understanding of 3 significant changes to the federal regs that occurred as of the end of November of 2017, and especially talk about the implications for recreational therapy practice, and perhaps give you a couple action steps in ways that you could apply this right away and go back to your facility and use some of this information. Overall, the changes that have been happening in long-term care have to do with 5 main issues, and we'll go into each of these with more depth, but overall, the focus has been on resident-centered care, also promoting competency in all staff and volunteers, and that includes documenting how you are creating competencies within your staff and volunteers. An individualized approach is very key in these new regulations in that we will no longer be having a cookie cutter approach to activities, but each resident's needs need to be taken into account. And one especially important aspect to these new regulations is the idea of using non-pharmacological approaches first before using medications. And there's a high emphasis on using activity-based interventions to work with people who have behavioral issues or pain issues, have dementia. And so I think that number 4 bullet is a real key for recreational therapists. 5th, the regs really talk a lot about quality of care and quality of life. And finally, I wanted to emphasize the idea that these changes, especially in terms of activities, are pervasive and consistent, meaning that the idea of engaging the resident is not just up to the activity director. It is also very important for the entire staff to be involved, and it has to be consistent on a 24/7 basis. So those are some overall comments. If you look at the regs as a whole, there are about 700 pages of the new regulations, and basically activities is referenced in about 52 of the regulations. So in order to pull this information, we had to look at more than just the activity regs this time and really look at overall what's going on in the changes in the regulations. If you, one of the things that we have done on some of these, I'm sure that you're familiar with the current regulations. So what we've done is put red lettering to show you the changes in the regulations. So resident rights changed a bit, and they added the words in terms of respect and dignity and a focus on individuality. And it is incumbent upon the facility to actually make sure that they are promoting the rights of the residents. And I think recreational therapists get involved in resident rights in many ways, but primarily we are responsible typically for the residents' council. And so we'll talk a little bit about what some of those changes will be. Another big piece of the residents' rights is this focus on individualizing care. So the idea is to really consider the residents' current and past lifestyle and their personal choices and really identify through the assessment process what this is. And the idea is that all staff and volunteers should be interacting with these residents in a manner that suggests that they understand them. And so I think there's going to be more emphasis in this idea that we know our residents, and the recreational therapist can be a key player in this, because we typically do know the residents in a unique and meaningful way. And another piece that's been told to the survey process is to ask the surveyors to really pay close attention when a resident or staff action may be limiting a resident's choice or autonomy. Jody, you had an example that you can share with us?
Yes, I'm sorry. I was looking for my notes on the bottom of the screen. They didn't pop up. We had a situation come up at the facility I work in where a resident was imposing on the rights of other residents. So that comes up sometimes, and the regulations don't specifically speak to that and how to handle a situation where a resident is violating another resident's rights. So we included our ombudsman in our planning process and our problem solving, and that worked out for us to be a really valuable resource that we don't always think to tap into the ombudsman, but they're also versed in these regulations, so they can help offer some guidance so that you're not in violation if you have a sticky situation like that. So that's something to keep in mind when you are working on individualizing something that is kind of an out of the ordinary situation. I just wanted to kind of add that little tidbit.
One key, I think, for the regs throughout the regulations is this concept of person-centered care. And we've heard a lot about culture change over the last 15 years and the idea of person-centered care, and it's very dominant throughout the industry, but it has really hit the regs in a very strong way, and I'm happy about that. I think it's great, and I think the recreational therapist should be able to capitalize on this, but the idea that individual preferences are important, and this extends to things like bathing schedules as well as activity calendars. Another piece of the regs involves self-determination, and again, it specifically talks about the idea that the resident has the right to choose their own activities, their schedules, when they wake up, when they sleep, and that they can make healthcare decisions for themselves. They should be able to make choices that are important to them. And I think this really is excellent, because if you've been doing culture change in your facility, for example, giving people the option to eat breakfast late, these regulations really support those kind of changes that people are making in their facilities. So I think that's very important, because years ago you would maybe have to have a conversation with the surveyor why you were taking a group of residents out for brunch and they were just having a bite to eat before they left. And they weren't having the full meal. Well, these regs really support that kind of choice as long as the resident wants to go. Another big piece is the idea of interacting with the community. And I know many of us are in charge of community reentry trips, and we take people out of the facility, and this is being emphasized heavily in the new regulations. And the idea not only to bring the community in, but also take people out into the community in their preferred activities. One thing that Jody and I both wanted to talk a little bit about is the idea of residence council. And one of the things that is specifically stated in the regs is that in your residence council, you need to provide the new residents' rights and make sure that you contact your local ombudsman for the new residents' rights. And give them a copy of both written and verbally, and go over those residents' rights in your residence council. This hasn't changed much. The facility has always had to provide space and provide a chance for residence council. But Jody, you were going to talk about a specific incidence where there might be a need for two different types of functional groups.
Sure. So we live in a rural area. Again, I'm using my facility as an example. And so a lot of the residents that we get are pretty advanced in their dementia process by the time they move in. And so we have had to, I'm going to talk about this again a little bit later, but we've had to kind of split this into two groups to make it meaningful. And later we're going to talk about the difference between providing different groups for functional need. This kind of fits into that thing where I'm sorry, I'm stepping on my words a little bit. When we offer two different groups for the basis of cognitive need, rather than splitting them based on certain residents don't want to associate with others, then that all of a sudden creates a situation where residents who weren't able to participate in a high level activity like a resident council meeting are then able to participate in a way that's meaningful to them. So what we've done is we will offer the resident council meeting, and then we'll have a more informal community group where the residents who are more cognitively impaired are a little freer to express themselves, where we can gather their information and apply it towards our resident council minutes, and make sure that their concerns are being addressed, that we're doing our due diligence with them, even though they can't verbally express themselves the way our higher functioning residents can.
And I think that's really important, because I have experienced myself running a residence council, and the only people that really get their voices across are the more high functioning folks that may have a physical disability. And so then you end up with, well, we want bingo 5 times a week, and that's what we want. And that is not necessarily what's best for everybody in the facility. So I think that's a really great idea in terms of including everybody and documenting that you're doing that and why you're doing it. Another piece of the new regulations is the idea of allowing people to do work tasks, and the idea that people can do them if they want to. And an example of this might be something like collating admission packets, or folding napkins, or folding towels, or helping with laundry, or setting up the tables for lunch. And all of that, we know all of those things can be very beneficial to residents in terms of them feeling a part of the facility, feeling a sense of responsibility and belonging. So it's good that those things are in the regulations based on resident preference. But I think you would definitely have to document the fact that the resident wants to do it, as opposed to being made to do it.
That usually comes out in the admission assessment of a past preference, or sometimes in the resident council meeting, that there's an expression that they would like to participate in something like that. So that's an easy way to kind of keep your paper trail going, to show that that's appropriate and that's their preference.
Right. Another piece that is very heavily emphasized in these new regs is respect and dignity, and the freedom from chemical and physical restraint. And I wanted to bring this up mostly because I feel like recreational therapists can be a consultant in this area, where if the resident is getting up out of their chair a lot, or they're at risk for falls, it's something that we can actually help the nursing staff with in terms of coming up with a plan that provides for the resident's needs without need of a chemical or physical restraint. But again, we need to do a better job of documenting our role in this and helping with this. And Jody was going to tell you a little bit more about a different type of mechanism she's been using.
Sure. So we use weighted blankets for our residents that have higher anxiety concerns, and that is still permitted if you're using sensory-based interventions. The thing that we've learned is that you have to be very careful in the way that you document it. You need to have a policy written on how you're going to use those sensory-based interventions. If you would like, at the end of this, if you shoot me an email, I have a policy on my work computer I can just shoot over to you so you can see an example. But the weighted blankets are still it's still possible to use them, but you have to make sure that they're not being used as a like a secondary restraint or an unintentional restraint, because if it's too heavy and the resident can't lift it off their lap, then it becomes a restraint. Just like bed rails, even though it's meant to be useful and helpful and keep them safe, it can be considered a restraint if they can't use them appropriately. So I just wanted to say that weighted blankets and different sensory-based techniques are still useful. You just have to be very careful on the way that you apply them and make sure that there is no possibility of restriction of movement.
Great. So that brings us to assessment, and the regs are very clear about how the assessment needs to be comprehensive. And I feel, this is my interpretation, that it does suggest that we need to go beyond the MDS. These particular regs seem to suggest that the MDS is a minimum data set, and yes, we need to go beyond that. But also the idea that every discipline should take into account every aspect of the assessment. And I think one thing that happens a lot is we divide and conquer with the MDS, and so we fill out section F and then that's it. But really, in all reality, the idea of understanding all parts of the assessment should be our responsibility. And I'll talk later about, and we can make available to you, it's on the ATRA website, the Bandy RT, which was developed by some recreational therapists and tested as well, which actually takes the MDS and has you review all pieces of it before formulating your goals and objectives. So I just wanted to bring that up, that I really feel that we're moving forward with the idea of rec therapists being responsible for the entire assessment, not just section F. Here are the aspects that they are including in that FTag 636. And then one of the things that are key in terms of as you're doing your comprehensive assessment, it is emphasized that the facility looks at a resident as a whole person and tries to see the person for who they really are and try to capture what's really important to them. So I'll be frank, if you look at the MDS, there's nothing on the MDS that will really do this. I mean, knowing whether somebody likes newspapers or not really doesn't capture what's really important to them. So I think it does call for us to go in more depth in terms of looking at not only like an activity preference, but going to an activity analysis where we understand past interests, present interests, things they would like to do more, and the frequency of which the activities were important to them, activity preferences were important to them. Jody,
there is there's a kind of a movement happening in long-term care right now for what's called an eye care plan. I'm going to get into that in more detail later. But if you're using an eye care plan, that's where this really kind of fits into, that is showing the resident as a whole person, because like you said, that the MDS and those types of questions, to make sure that that's satisfied, isn't showing us the personality behind. And sometimes we can just capture that even just in an open dialogue box in our assessment. If you use a system like Point Click Care or something similar, you can create an admission note attached to your assessment that captures like their facial expressions or how they interacted with you, or the delay in verbal response, things like that really are important for socialization, or just these details of what makes them them. So just want to say to that there's a lot of creative ways. And we work with the creative people of the team typically. There's a lot of creative ways that we can capture that on the assessment and make sure we're still meeting the things that we need to meet, but we're not losing the person in the paperwork.
Absolutely. I did want to mention that nothing's really changed with the MDS in terms of these regulations. Everything is very much the same with the same acronyms. So not much to say on that, except that we need to go beyond it. The quarterly review is still the same in these regs. One of the things, though, I do think it does point out for the surveyors when they're coming into your facility is they want to make sure that qualified professionals are administering it. And again, this is important that the CTRS should be the one doing the assessment. I think that that's typically what happens, but I have seen some instances where the activity assistant ends up doing the assessment, and that's pretty clear in the regs that that shouldn't be happening. And also the surveyor is actually instructed to make sure that the assessment actually compares very well to what they're seeing with the residents. So that suggests that if there's a resident change over time, that you need to do your assessment more frequently or update, and especially in your progress notes, changes in that resident. So they are saying to the surveyor, interview the resident and their family, and if they don't match the assessment, then there's a problem here.
And it's okay to get input from your CNAs, but I've seen some places where CNAs were filling out some of the quarterly assessment, and that's really not okay. It's okay to get their input for what they see when you're not around, because you typically have a different relationship with that resident than the CNA does, so they see a different side. So by all means, get their input, just don't delegate that task to them.
Absolutely. The care plan, again, there's a focus on it being person-centered and supporting the resident in making decisions. There's a lot of discussion also in the regs, and I didn't put this on the slide, about having the resident representative present if the resident's not able to voice their own decisions. And really focusing on that resident as a center of control, making sure that that resident is really able to understand even with the communication challenges that they have. So again, that focus on person-centered care is all throughout the regulations. One thing that's new this time around is the baseline care plan, and it must be done within 48 hours. It's basic initial goals that should be done, and it is the 48 hours after admission. So if somebody is admitted on Friday night, this care plan must be done in 48 hours. So we're talking Sunday night. One of the things that it's not specified in the base rules that activities is on it. However, when you go into the critical pathways for the surveyors, which I read, it does say that at least nursing level activities must be suggested in the 48-hour care plan. So that is something that I would say you should go to your administrator and director of nursing and say, you know, we need to be part of this. I know in some ways it sounds like you're asking for more work, but it's important that we are seen as essential to the management team of the facility, and very important. And it should be that they can't get along without us. Jody, do you have any thoughts on that?
No, I think it was back one slide, but I can also say it with this one because it all kind of fits together. The iCare plan is where this can be really useful if it's something that you have implemented or you're interested in implementing. This is very similar to the regular care plan that we all do, except it has a little bit of different phrasing. So in an iCare plan, instead of saying the resident will X, Y, and Z, you would say something like, I like to read the newspaper on Sunday morning. And then you'd make your interventions to match. So this is a way that we can personalize the care plan and make sure that it is resident focused, that it's resident initiated, that it's their self-determination. It's going to fit into all of that. And this is not, I just want to say also, this is not required. This does not show up in the tags as a requirement, but it is starting to become a preference as more people are doing it because it is much more personal. So surveyors are aware of them, and they're starting to do some training on their interpretation, how to interpret them and everything. So this is something that you might want to start, because the activity section is the easiest section of the care plan to start something like that, and kind of encapsulate all of those things in a very resident-oriented manner.
There's in the comprehensive care planning section of the regs, there's a real focus on engagement. So I think that we should be looking in the future to look at an engagement measure as opposed to participation measures. Mm-hmm. And I mean, that is something, there is one engagement measure out there. I don't have it to present to you today, but I think that that's something the older adult section can work on and get to everyone. But really focusing on measuring the residents' engagement versus their participation. And also there's an emphasis in the idea that resources for activities should be available on a 24/7 basis. So if the resident wakes up in the middle of the night and needs to be engaged, that nursing staff has what they need. And so I think that, again, we're going to, as recreational therapists, we're going to need to think of ourselves more in a consultative role at times, not just the person that is providing the service, but also what's happening 24/7 in terms of individualizing sensory boxes or whatever that resident needs when we're not there. One of the things that the surveyors are asked to look at is, does the actual care plan relate to the assessment, and have all of the resident assistants, the activity assistants, all the direct care staff, have they all been educated about it? So it's not good enough that the director of nursing and the activity director know the care plan, but the direct care staff should know it. And I think that's, again, an area where we can be helpful. I think that breakdown in communication is often a huge problem between what's written on the care plan and what people that actually work with the residents know. And those are areas that can really be worked on. One thing that's specified is that we must have a dementia-specific care plan for those that have cognitive impairments. So, and dementia-specific activities, and we'll get to that in a minute. The care plan must be done 7 days after the assessment, 21 days after admission, and obviously must be interdisciplinary and evaluated for effectiveness. And again, that really hasn't changed that much. However, I think there's more emphasis on the comprehensive nature of it. I just wanted to mention that discharge planning is written in there as well, and this would be especially important for those residents that are in your swing beds, or those that are coming for rehab for a short stay, and you need to be working on a discharge plan with them, and the idea that they're the active partner. Some of this language comes out of the Affordable Care Act and the idea of continuity of care back to the community, and that transition should be smooth and that there should be good communication. And so that is definitely part of the Affordable Care Act. Quality of life, again, is mentioned, and the idea is that each resident should be able to have full well-being, and it's not just a physical well-being, but it's also mental and psychosocial, but also an emphasis on changing the environment. And in fact, there is a packet that the administrator and DON have to fill out where they look at the environment and talk about how does the environment humanize and individualize care for each resident. Jody, did you want to talk a little bit about that?
Yeah, so this is where we kind of shook things up in my facility a little bit, and we kind of we realized that we had kind of some gaps in between each discipline working independently. So we had a restorative aide that worked under the direction of the restorative nurse, and I'm going to say her because it just happens to be a her in our facility. And what we did was we changed her title from restorative aide to therapeutic aide. And we now share her between the restorative nursing activities and occupational therapy. And the social worker is involved sometimes, but not as much as the three of us. And so what we what we did there is, by making it a team effort rather than each of us doing our own job, we've seen our quality of life and satisfaction reports from residents just skyrocket because we're doing this more comprehensively. We're really focused on resident needs and resident outcomes, as well as the one whole person, and that's really, for the psychosocial well-being, has really been very beneficial, as well as physical functioning. If I'm going to be honest, having this more centralized kind of approach, we have really increased the quality of the care that we're giving, because it's not Jody's doing this, Adam's doing this, Vicky's doing this. It's we're all talking about one goal or a couple goals, and how we each can play off of each other. So my occupational therapist will come to me and say, hey, this person can walk this many feet. I think they're ready to go try community distances. And then we'll talk about that. The restorative nurse will say, oh, make sure that, they have this medication first, that they're being aware of this and this in their transfers and whatever the restorative nurse is working on. And so that has really helped us create an atmosphere that is, I'd almost like breathe new life into our residents, because they're actually getting to live their life and have it be meaningful to them, not by anything that we changed for them, but the way that we approached it. So that might not work in your facility. That's what worked in ours, but we're also a small facility in a rural area. So I just want to encourage you to just kind of be a little bit creative with how you look at your staff and see what your staff can do to change this, maybe in their approach. It doesn't necessarily mean bringing in new supplies or new equipment, but sometimes it's just we can change things dramatically with what we already have.
Excellent. One of the things I wanted to give you was just the CMS's definition of quality of life. So I'm going to go through this really quickly, how they define it. I think quality of life can be one of those concepts that's very vague, but how we need to know how they define it. And it's a sense of well-being, satisfaction with life, which goes along with what Jody was talking about, a feeling of self-worth and self-esteem, and then satisfaction with themselves and the environment, care received, accomplishment of goals, control over their life preferences, choices, and beliefs. So CMS does extend quality of life quite a bit in terms of that idea of satisfaction is more than just your satisfaction with your physical well-being or your health, but also the whole environment and feeling satisfied with that. And I think along with that suggestion is this idea of it needs to be more home-like environment. Activities of daily living are discussed and definitely emphasized. I'm not going to go into it too much, but kind of going along with what Jody just shared about partnering between OT and the restorative nurse, all residents should be given appropriate services so that they can maintain their ADLs. And that includes hygiene, mobility, toileting, dining, and communication. So like a good example of this might be that working with a resident to walk to dining, working with a resident to transfer into a chair for dining or transfer into a chair for your program, as opposed to staying in their wheelchair during the program. And that takes extra effort, but those kind of things help the person actually, wait there one or two more times and gets them into a socially a more accepting home-like situation if they're sitting in a nice chair versus sitting in the wheelchair at the table. So those kinds of things that we can help with. And I think also just, focusing as well on integrating water breaks into everything that we do to help people in terms of their hydration and those kinds of things can be a main part of what we do as well. The new FTag for activities is now $6.79, and basically it has changed quite a bit. You can see in red the word changes. that it is tied to the comprehensive assessment. So we're going back to that idea of comprehensive, and it is based on the resident's preferences. It's focused very much on meaningful activities and supporting the resident's choice, and the idea to encourage independence and interaction in the community. Well, again, these various levels of programming have been mentioned in the new guidelines. So it is very clear that we should be doing more than large group. So yes, it's fine to have facility-sponsored large groups, but there's also room in the regulations for a structured day with task segmentation for your residents that have dementia. So they're opening the door for this idea that there are going to be different functional levels of residents, and there are going to be different needs. Whereas your residents with dementia are going to need a different task-segmented activity-based intervention every 30 minutes during the day. There may be residents that are there for a hip replacement that will, need a different type of individualized programming to help them meet their rehab goals. So it's very focused on this idea of individualization, and we're definitely no longer is the idea of bingo and birthday parties enough. Mm-hmm. So we're definitely moving out of that.
This providing the various levels of programming is something that people who've been in the industry a long time, some of them have been struggling, especially ones who are not in rec therapy. So what you might hear from your interdisciplinary team is that this counts as involuntary seclusion. If you're having two groups going at the same time that are based on different functional needs, this is not, and that's, I think, part of why this is spelled out this way, is you can provide two groups. This is the way that I do it right now, is I can have something that's a high functioning activity that's geared for high functioning residents. And then I can also have a more simplistic task or something that is more Montessori based. And I offer those at the same time. And naturally, the people who should be participating in them, where they're the most beneficial for those people, they naturally divide into those groups. Now, where this is not involuntary seclusion, if I said, you have to go to this group and you have to go to this group, it would be. If you have it open to whoever wants to participate can, then you're okay. You're safe. You're not going to get cited on that. But you will see kind of that natural gravitation towards something that is going to be either challenging or comforting for them. And so this can be a way of making sure that you're providing for everybody in a way that doesn't get your residents fighting with each other or irritated with each other, or particularly those higher functioning residents sometimes pick on the lower functioning residents, which, if you're like me, it just breaks your heart. So this is a way to kind of avoid that whole situation.
Again, the activities should be ongoing and resident-centered, and lots of emphasis on the fact that the entire facility should implement. So if your nursing assistants are not involved in any way, and if your 3 to 11 shift has nothing going on, these are things that you need to look at. All team members are to assist, and it's spelled out very clearly. And these are things that you can go to the actual regulations and show your director of nursing if you need to. Don't take it from me, but you can actually go to these particular regs, and it's very clear that it's not just the activity department. The intent of these regs is to support a meaningful life and wellness for the resident, and to really focus, the regs focus on autonomy, security, growth, connectedness, identity, joy, and meaning for that resident. So it is seen as central and not just a sidebar or an added service, but something that is integral to the resident's life. And activities are any endeavor other than a routine ADL. So yes, doing the resident's nails or manicure that you set up with your nursing assistant, that is considered an activity, as long as it's not a routine ADL. And so one of the things that, I did in my practice was actually have nursing assistants do, as part of the day, do things that were within their scope of practice. And then I did specialized groups for the residents that were within my scope of practice. But I think the top down, bottom up has to be engaged in this process. And it can't be seen as the activity director's responsibility only. It has to be seen as a total responsibility by the facility. Again, there's a focus on Maslow's hierarchy of needs with activities, and that they should be promoting independence and self-esteem, comfort, education, creativity, and success. And I would say that we should really, really think about how we're documenting this. Do you want to talk a little bit about that, Jody?
Sure. This is another area where the iCare plan can be really useful to us. And I don't mean to just keep pushing this iCare plan, but it can be a really useful tool, because you can document in let's say your care plan, something, let's say, I'm just coming up with one right now, like I feel a sense of accomplishment when I paint, or something like that. If that's what that is meaningful to that resident, then that can fit in your care plan. And then you're implementing activities based on that and giving them resources for it. And then when you go to do your evaluation or your progress notes, then all of that is really tightly packed in there, where you can see where you're using this hierarchy of needs, where you're talking to the resident, where you're individualizing things for them. And it kind of makes this nice cohesive picture. So just think about that as you're working towards, if you're improving your assessment process or your care plan process. There's other different tools out there besides the iCare plan. That's obviously my preference, because I feel like it's the easiest to use and it's the clearest to use. But you can use things like that to make sure that the information that you're communicating to your surveyors, to your team, to your administrator, your director of nursing, whoever, is the information that you are trying to communicate.
So meaningful activities are integral to the whole process. And I can't emphasize that enough, but I think that the big picture is that it applies to every resident in the facility. And also this idea that every person has unique needs and preferences. So I think we need to do a better job of means that it needs to be something that, I know we have issues with HIPAA sometimes with putting up people's preferences, but I think, how are the nurses aides or CNAs actually going to know what those preferences are if they don't have it available to them? So how do we get that information across? It's one thing to gather it from the family. It's another thing to communicate it, again, to all staff, all shifts, because I think, we all know how does the 11 to 7 shift know about the fact that that person likes to sing "You Are My Sunshine" when they're anxious? So we need to, make sure we figure out how we can communicate better those things. I think that we need to make sure that we're expanding beyond the activity director and the activity volunteers, and we need methods and systems in place. And I would say even one of the things that's emphasized is actually having a quality improvement plan for your program. And obviously that's part of the ATRA standards of practice. If you're using the ATRA standards of practice, that you are evaluating your program. But even in the regulations, they're saying that every activity program should have some kind of quality improvement process. And so as long as you've documented that you're working on these areas and how you're doing it, that's what you need to do. None of us can change things overnight. We have to have an incremental plan about how we're going to make things better. So I don't want people to feel like, a sense of panic. I think it's more about having a method and system over time to improve things. And you could show that to a surveyor. This is what I'm working on. And I think that would go very far. All right, so along with the activity tags, they've actually specified in their specific activity interventions. And so one of the first things they specify are dementia-specific activities. And again, this should be an area where we are key, that we have been trained and we know what to do and how to set up dementia-specific activities. If you haven't had a chance to take the dementia practice guidelines, there are other options out there, and the older adult section can help you with this. But we are the people to set these up. And the idea is that the dementia-specific activities should be very individualized and appropriate to their previous lifestyle. So, you know, the lawyer that you have in your facility, that he can carry his briefcase to the program that you're doing and have a role in the program based on his background, while the person that was a kindergarten teacher has a different role. And so that we really have a comprehension of those roles and what's important to them as they come into our program. One of the things that I think is fantastic about the new regs, and we need to capitalize on as rec therapists, is the idea that they have actually taken behaviors, specific behaviors, and linked them to activity-based interventions. And again, I can't say strong enough that rec therapists need to be at the forefront of showing how we are specifically prepared to do this. And so these are the behaviors that CMS has outlined that they want to see activity-based interventions linked to. So if I'm a faculty member now, but what I'd like to see is a group, an intervention for each of these areas that we are specifically in our manual saying, you know, this is what I do for this particular group of people that have this behavior. It's so exciting because we can begin to individualize our interventions based on outcome versus just doing an activity for the fun of it. And again, we need to capitalize on this as rec therapists. So I'll go through these very quickly. You can go to the reg yourself, but basically if the person has unusual energy in walking, they've specifically stated these are activity-based interventions that should be taking place. So we need to like change the environment. We need to use aromatherapy, validating and engaging the resident, a garden or a walking path. Again, you can't make a garden or walking path by yourself, but again, if it's in the regs, the facility is going to be more open to it than ever before. Resident that has behaviors that are not conducive to a home-like environment. I think this is perhaps the resident that is in a public area and the behaviors are not conducive to other residents that are around them. So they're suggesting particular activities for them. And I think that we should, as much as we can, talk about these with our director of nursing and the administrator as activity-based interventions. Try to get away from saying activities and try to get that intervention piece in, because again, it is cropping up in the regs, and I think we should be at the forefront of that. We shouldn't have an activity assistant doing an activity director role. Interventions. That's a rec therapist role. So behaviors that require less stimulating environment. So again, there's this recognition that some people may need stimulation, other people may need less stimulation, and we can gear our program specifically to those. So if you look at this list, we're doing this. We just need to document it. Going through others' belongings, the idea of providing work tasks that will help people that are rummaging through other people's rooms or going through other people's belongings by setting up a rummaging area or having them folding laundry or sorting to meet those sensory needs that they have. Attention-seeking behaviors. Again, to me, these are things that I would do naturally with people, but I think, and I know many of you already are doing them, such as giving the person a role and having them do service projects if they have attention-seeking behaviors. But again, we need to do a better job of documenting that, not just doing it naturally, but documenting that the rec therapist is setting these particular groups or individuals up with these particular interventions. If someone lacks awareness of safety, I think this would probably be the person that's at risk for falls. And, you know, we know that there are many, many people in our facilities that are at risk for falls. So, you know, being aware of those particular residents and having fall prevention groups, I think would be really wonderful way of addressing this. For the resident that's isolated in their rooms, kind of going back to what Jody talked about is, you know, some people have chosen to stay in their rooms, and we can't violate their rights and say you have to get out of their rooms, but finding ways to interact with them and making sure that their needs are being met as well while they're in their rooms. And Jody, I don't know if you had anything specific that you'd like to talk about, but I do think this is a tough one because it does get to that idea of resident right to not participate in the large group, but also making sure that we are providing something for them.
What I do in my facility, oh, I've got an echo. Is, maybe I should back up a little bit. Is I check on those people every day. I might miss a day here or there in a week, but I try to check on them every day to make sure that they're having the opportunity, and that's what's in their care plan, is that they have the opportunity to participate when I write about their preference to stay in their room. So the key to that in terms of documentation is if you write in their progress note or in their care plan that they do not participate in scheduled activities by choice, or their preference is independent activities, things like that. You want to make sure that you're using those keywords in your documentation to make sure that it doesn't look like this person just stays in their room and we just let them. You know, that you want to make sure that you are showing that you are honoring their preferences rather than just leaving them to their own devices.
And finally, they do talk about delusional activities and hallucination and working on for the resident in that situation. I think we're uniquely qualified. I mean, all of our students that are coming out are getting at least 3 classes in psychology, and they are well qualified to work with people who have behavioral issues. And I think that we need to make the most of that in terms of having the CTRS that's very well qualified to work with people who have behavioral issues and dementia. One of the things that we did want to bring up to you is the next guidelines. It's 680 now that talks about the qualifications. And one thing, you know, CTRS is the first one listed. And basically the qualifications haven't changed, but you know, Jody had mentioned to me that surveyors are now saying that they are preferring a CTRS.
The ones that I've talked to have stated that because there's now the new regulations about behavioral health and a lot more emphasis on dementia, that the CTRS is the role that they're going to look for first. They're going to almost expect a CTRS unless they're told otherwise, which is great for us.
Absolutely. And I think, you know, we need to capitalize on that again. And students that are going out into the field need to be able to use that credential well and explain it well. And so we need to help them as well. And the older adult section can do that. All right. Really quickly, the FTag for quality of care is 684. It's really no different than a lot of the things we've been talking about. I wanted to bring up that in the 2006 regs, that the interpretive guidelines were very specific under activities. Now they're spread out and distributed through the other FTags, which we don't have enough time to go over today. But make sure that you understand that every single disability or impairment has interpretive guidelines based on activities. So we need to be addressing pain. We need to be addressing visual impairments. The person that has varying sleep patterns. Those are things that we should be addressing through activity-based interventions. The bottom line is activities are an interdisciplinary endeavor. We need to do a better job of identifying and documenting and communicating. And there should be meaningful activities across staff and shifts. And then I think that we need as rec therapists to begin to think about, okay, so if there's meaningful activities across all staff and shifts, then we should be doing specific interventions for specific outcomes. These are focused groups, whatever you want to call them, that the rec therapist is leading that have specific outcomes. And then making sure that we're the consultant to the rest of the facility so there's meaningful activity where residents are engaged 24/7. And no longer is there an emphasis on each function having a separate aide. The universal worker is now completely acceptable. So if you want to have a CNA that has training in all areas, that is completely acceptable in the new regulations, which I'm very happy to see. One of the things I did post for your benefit was the non-pharmacological interventions for pain. And again, we need to have guidelines. A rec therapist should be working on pain management, and that could be a specific group that you have or specific individual intervention that you're doing. That's one of those focused interventions for rec therapy.
You want to make sure that you have a policy in place for that your administrator or your DON signs off on, just so that when your surveyor does come in, they don't say, why is the rec therapist managing pain? Why aren't you giving a medication? You want to have a policy in place that specifies under what criteria you're going to do those interventions.
Very good idea. And then another thing that's new in the regs is PTSD. And it's not just veterans that have PTSD, although we typically think of that as a veteran-focused problem. And there are many people that could have PTSD, and it might appear after the person has dementia, where they had never really expressed it before. And there was something very deeply embedded in their memory that comes out during that time. Behavioral health is very heavily emphasized in these regs. And I think what you'll see more is a social work and activities working together to execute a plan for behavioral health. And we will be doing specific interventions to really promote behavioral health. These are some things that are mentioned in the regs specifically in terms of non-pharmacological interventions, hydration and nutrition, individualizing sleep and dining, and meaningful activities based on comprehensive assessment and lifelong patterns that include music, art, massage, aroma, and reminiscing. So those are things we're doing, and we need to definitely document it. Dementia care is mentioned again in the behavioral health regulations, and we've been over that in some depth. One of the things I did want to mention is that there is a new survey process, and it basically combines two of the older processes. The surveyors currently, from my understanding, are still kind of being trained on it, but it involves a lot more in-depth observation and interviews with the resident and their representative. And so they've been told to actually do fewer residents, but make sure they're going through all the critical pathways with those smaller groups of residents. So they're supposed to do about 35 residents from my understanding. And they actually review the facility matrix that's generated from the MDS before arriving at the facility. So they're kind of aware of some of the problems that you might have. And they're much more resident-centered. So the surveyors are being told to be much more focused on resident processes.
There is a new survey window. I'm not sure that this is in every single state yet, but I know it is in several, including Michigan, where they don't have to necessarily come in that block of time that we used to have. Now they have a certain number of facilities that they need to visit within a year instead of visiting every single facility in a year. So you might go 2 or 3 years without being surveyed, or you might be surveyed 2 or 3 times in the same year. So the reason behind this is to kind of make sure that everybody's ready at any given time to be surveyed. But it kind of makes it unpredictable to know when the state's coming in. So it's a good thing. It's also a stressful thing because of that. But just know that your survey window may have changed.
Okay, some takeaways. We're heading down the home stretch here. First of all, I think as rec therapists, we should be focusing on engagement and quality of life in the way that we talk about what we do rather than activities. I think we should start focusing on activity-based interventions that we're specifically doing and see activities as a whole facility process. I think we need to do a better job of advocating for what we actually bring to the facility. So many times administrators have seen us as the people that do the birthday parties and the big social events that will promote admissions or make the facility look good. And we need to advocate for the fact that actually we're helping them more with the CMS guidelines, and we're going to keep them from getting problems with the survey process, and we're going to be an integral part of the team. We're not there to sell the facility with special events. I think capitalizing on the regulations' emphasis on individualization and non-pharmacologic approaches is a really important way to go. And I'm really happy that the surveyors are starting to recognize that the CTRS credential is important in terms of this. I think you are the only one who can actually expand your role as a specialist. You're the only one who can let other people know, hey, I have these abilities to help you make sure that we're meeting these regs. And I think being informed about the regulations is so important. Don't let the director of nursing tell you what are in the regs. You get yourself educated on them so that you can advocate for yourself. We have to move away from cookie cutter approaches, and that includes calendars. The calendars should be more of an evolving type thing rather than something that is just cookie cutter and the same thing each month. We need to move away from that. I never liked that anyway, but we need to see ourselves as interventionists, not as activity people. I think we can go back to the APIDE process when we start thinking about how we are implementing this. So with the assessment, thinking about how can we actually revise what we're doing in terms of assessment and go beyond the MDS. And so if you can take a look at the Bandy RT, I think that will really help you with that process. It's something that's already been developed. It's on our website under older adult. Making sure that you are included in the baseline care plan and that your care planning is comprehensive, not just cookie cutter. Making sure that you're actually implementing in a way that provides access to all staff and all residents, and making sure that you have a quality assurance, quality improvement, performance improvement plan, whatever you want to call it. It's all about evaluating your program and showing what your plan is to make it better. And then making sure that all of this is documented so that you can show what you're doing. It's not just documenting in the resident record, but also having your policy and procedure manual show that you have all these things in place. I did mention the Bandy RT, and that is available to you on the website. I think in terms of planning, thinking about an evolving calendar is really helpful. Jody, did you want to talk a little bit about an evolving calendar?
Well, one thing that I moved to, because, if you plan a calendar for a month at a time, then you have no idea who's going to walk in the door tomorrow. So what we did is based on our QAPI analysis, that we do for every quarter. We evaluated the information we had from that, as well as every month from our resident council, and every assessment that you do, should feed into your calendar and talking with your residents. I make a month calendar, but I make it for a week at a time, and I put each week together. And that way, if something drastically changes, or again, I live in northern Michigan, so our weather is very unpredictable, we can change a week out very easily. So that's one way that you can kind of do that evolving calendar in a way that's not creating too much extra work for yourself.
And I don't know what the states are requiring individually, but I would say having more individualized calendars versus relying only on that big calendar in your facility. I used to do one calendar per hallway. We had functional groups, and people were living in neighborhoods based on their cognitive status or level, and so I would actually do a specific calendar for that particular hallway. I don't, not everybody's in that situation, but we need to get away from that big calendar ruling the roost. In implementation, just making sure that you have some kind of 24/7 plan, evaluating, making sure you're documenting your own department's performance improvement and what you're doing. And so Jody and I wanted to provide you with a little bit of homework here and kind of thinking through maybe how you could start this quality improvement process. So one of the things we were going to suggest to you is kind of start with 3 or 4 medical records and actually just looking at them and do you see if your assessments include the whole person, seeing if they go beyond the MDS and actually have some kind of activity interest inventory that goes beyond just a list of preferences, but that more in-depth look at that preference for the person, like if they like books, what kind of books, that kind of thing. Are the care plans that you've been doing, do they all look exactly the same? Because if they're 4 different residents, they should look very different. There shouldn't be the same exact wording, the same exact goals. We need to get away from the cookie cutter approach to residents. Do we see meaningful resident engagement integrated into all areas of that resident's care? Because basically remember that all the surveyor can do is interview the resident and look at what's written. So it doesn't matter what's in your head or what you do, but what's written there, does that actually show a unique individual? Kind of looking at your overall calendar and seeing what's on there besides bingo and birthdays. Can you link the residents' current preferences, the people that are in your facility, with what you're offering? And some of the things that Jody suggested, I think, will be really helpful. And then how are you empowering your staff to know about the uniqueness of each resident? How can we make it important to them? How can we make that information available to them? Because they may not have time to gather it or the ability to sit down with the resident, interview them, and get that information. There are some great resources for you, and again, we're making them available to you on the ATRA's website. Making sure that you use the ATRA's older adults section. It's just a wealth of knowledge and information, and that section is there for you. It's a member benefit, and so as much as you can, use that and be active in it and share with others. I'm sure most of you have a lot to share with us as well on how you are working with the new regulations. Any final comments, Jody?
I don't think so. I think we covered a lot. I do want to say, if you have any questions about any of this, feel free to reach out. We're here to answer your questions. If you send it to the older adult section, those get forwarded to me if they have to do with FTags. So by all means, ask any questions that you like, because we're here to help you.
Thank you for giving us your time.
No problem.